Hello and welcome to this video, which is a case study showing some of the challenges that we can face when it comes to IOL exchange surgery. Now, as a surgeon, we have to make a careful decision when it comes to considering lens implant exchange for patients. In this example here, it's a patient who has unmet expectations following implantation of bilateral PanOptix multifocal IOLs. In addition, he had two quite heavy forceps marks, which don't show very well on this particular image, but the patient was able to visualize the area of the disturbance on the optic and wasn't able to adapt. And given the fact that he had unmet expectations, as well as this slightly malpositioned implant and some marks on the implant, I felt the best option here was IOL exchange in favor for a extended depth of focus lens implant. So here you are seeing the main incision being made. It's important to plan the positioning of the incision so that it gives you maximum accessibility to the optic and the haptics. I use a single 2.5mm main incision and two side ports to facilitate this process. I also routinely use a dispersive viscoelastic in order to help protect the corneal endothelium in these cases, simply because there's a great deal more surgical manipulation going on inside the eye. Now you'll see here that the inferior capsular leaflets are partially fused. The implant is slightly malpositioned superiorly. One of the reasons perhaps why the patient has significant dysphotopsia and dissatisfaction. And so part of the challenge here is to be able to try and open up the capsular leaflets to allow mobilization of the optic to start with. You can see that this process takes a little bit of time, and gentle coaxing and maneuvering of the optic and getting a cleavage plane underneath the capsular rim, and of course using viscodissection techniques wherever possible to try and just gently coax the optic and allow maneuverability. You can see that the implant is fairly well tethered, particularly at the haptics, and this does require very careful surgical manipulation, because of course the main issue here is to protect the capsules, the capsule and the zonular apparatus as much as possible, so that we have a great chance of being able to implant the chosen lens implant into the capsular bag. Thankfully, this patient has not had a YAG laser capsulotomy, and unfortunately in the other eye the previous surgeon had performed a laser capsulotomy, which makes IOL exchange more problematical. But thankfully we were able to use the fact that the capsule remains closed at this stage to attempt the IOL exchange with minimum disturbance and hopefully a lower risk. So much of the time here I'm using viscodissection techniques to try and free as much of the intraocular lens implant as possible. We've got a nice cleavage plane now. We can get underneath the capsular rim, and the capsular leaflets are now opening up, which is allowing the optic to become more mobilized and free. So things are going pretty well at this stage. You might have noticed that I've listed the fact that this surgery is being done under topical anesthesia with some intracameral mid-drain anesthetic. And the patient remained comfortable throughout. So you can see I'm exploring the adhesions around the haptic at the inferior pole here. Both haptics were fairly adherent, and we're going to tackle the proximal haptic here. You can see a lot of tethering here, and very, very careful, gentle manipulation remembering all the time that preserving the capsule and the zonual apparatus is really important. You can see here that the distal bulb of that haptic is really tethered to the peripheral capsule, and it's certainly causing some strain on the zonular apparatus. And this does appear to be a common problem with the single piece C-loop haptic IOLs. And I've just slowed the video down here so that you can see the amount of strain that's being produced, and that's clearly not going to come without some damage to the zonules and to the capsule. So therefore I felt that this was a good time to change tack and move on to a different approach here, which is to cut the haptic. And the plan in my head at this stage really is to perhaps do the same thing for the other haptic, but let's see how we can now manipulate that haptic out. And again, you can see a lot of adhesions, this time more proximal adhesions at the haptic optic junction, and again, after a little bit of coaxing and gentle manipulation, I gradually come to the conclusion that we're going to have some difficulty in removing that haptic without first perhaps cutting the haptic at that junction there. I have managed to remove some of the adhesions there, just using a biomanual technique. So once again I move to my other approach, which is to cut the haptic optic junction here, and the plan then is to remove the optic. And what that does, it gives us a little bit more space and freedom to work on removing the haptics a little bit further down the line. So all the time we're trying to minimize risk and make life as easy as possible for ourselves and for our patient, and a biomanual approach to cut the optic in half, therefore being able to extract the IOL through the small incision. One of the things I find when we're removing the cut optics is a little gentle digital pressure on the posterior lip of the incision that will help to extract the two pieces. And this optic came out quite nicely without any great difficulties. So at this juncture we're now able to use the freedom of the space that we have to go in and use a little bit more viscodissection techniques to open up the capsular bag as much as possible. And it's quite hard to see in the video, but again I'm using some viscodissection here and gentle maneuvering. You can see that the distal bulb of the haptic there suddenly became free. You can feel that in your fingers, and that always helps. It's very hard to convey that detail in the video, but certainly it felt suddenly become more free, and the more proximal element of the haptic here is also still quite adherent, but gradually and with a little bit of time. Remember, IOL exchange is not the kind of surgery that we can rush. We have to take our time. We owe it to our patients to give them the very best chance possible of successful surgery. And here we can see the haptic is now partially dislocated. We're now able to go in with our microforceps and gently maneuver and coax that haptic away. And it just comes free. You can feel that force giving away very, very easily there. Now it's back to the more sticky of the two haptics, the proximal one as it were, and you can see here that that distal bulb still is very, very adherent. It's in an awkward position. This is one of the problems that with IOL exchange surgery. Sometimes the adhesions are in your favoured place for surgical access. This is one of those examples here where the haptic really isn't going to free without some damage to the capsular zonular apparatus. And so after a little bit of further exploration and attempting to free that distal bulb, I make the decision that the risks of further manipulation are increasing, and ultimately one of the tricks we can do here is, given the fact that this is a very adherent area, is to cut the haptic as kind of far as possible towards the adherent end, which should allow us to remove the bulk of the haptic, but the little distal bulb can remain in situ. It's certainly not going to come free, and it's quite safe to leave a small element of the haptic in the eye. It's certainly a far more preferable outcome than having significant complications which then require potential vitrectomy. And you can see that the distal bulb there slowly retracts back into the far periphery of the equator there, and it should be absolutely fine. So now we can go back in and do some further viscodissection, making sure that as much of the capsular bag is open as possible to allow the next implant. The plan here was to have a extended depth of focus implant. The Zeiss AT Lara IOL was my favorite choice in this particular example, and being a plate haptic, I wanted to make sure that the area where the plates would reside is as free as possible from adhesions to give us the best chance of a well positioned, well centered extended depth of focus lens implant. You can see still some adhesions at the upper pole there, and you know, there's no rush. We just take our time and we ensure that there's as much freedom as possible, because the last thing we want to do now is put an implant in and find that it doesn't sit well inside the capsular bag, and then have to remove that implant and go back to plan B, which is to maybe use a sulcus fixated monofocal IOL. That was my least favoured option in this particular case. And you can see we are now able to inject the Zeiss AT Lara EDOF IOL into the capsular bag, and it unfolds quite nicely and resides comfortably inside the capsular bag, and positions centrally, positions well, and is stable. So all looking very positive at this stage. Just a little bit of manipulation, making sure that the optic is well centered and well positioned inside the capsular bag. We've got good rim support here, so I've got no concerns about the positioning of the IOL. And now we're on to the home run, or the last wicket, and bimanual irrigation is my favorite approach for removing viscoelastic material both behind the IOL and in front of the IOL to help reduce the risk of postoperative IOP spikes. And I did notice in this particular case that there is some element of posterior capsular fibrosis, which will probably require a laser capsulotomy procedure at some point in the not too far off future for this patient for his final visual rehabilitation. Now that the viscoelastic is all fully removed, we can move on to the final phase of the surgery. So it's time to hydrate the ports. And finish off with some intracameral cefuroxime as a standard part of our intraocular surgery protocols. And we can breathe again now. So I hope that you've seen some of the various challenges that we can face when it comes to IOL exchange surgery. And I'd love to hear any comments, positive or negative, regarding the surgery, and I'm particularly interested to hear what people might have thought about in terms of alternative approaches here, because there's always more than one approach in these sort of cases. Thank you very much for watching.